Okay, let's unpack this. Welcome back to the deep dive.
Great to be here.
Today, we are plunging into a topic you've asked for, especially if you're tackling exams like the MSRA. Infantile hemangiomas may be better known to some as strawberry naivy.
That's right. The strawberry Naevus, very common, very important for exams.
Our mission is simple but crucial: to extract the absolute most important, high-yield information from the sources, structuring it like a targeted audio revision session.
Like a quick audio cram session focusing on what you really need to recall.
Exactly. We're going to cover everything from what these are to why they happen, what they look like, and, most importantly, how they're managed.
Let's do it.
Let's jump right in with the fundamental question. What is an infantile hemangioma or a strawberry Naevus?
Okay, so at its heart, this is the most common vascular tumor you'll see in infancy. It's benign, meaning it's not cancerous.
Right, benign.
And it's basically characterized by an abnormal growth of blood vessels.
And the common name, strawberry Naevus, gives you a pretty clear picture, right? What does it typically look like?
Exactly. It's usually a raised lesion, often bright red or maybe deep red. And when you touch it, it's typically soft and compressible.
Soft and compressible.
Yeah, it really does resemble a strawberry, hence the name. It's quite descriptive.
Now, the natural history of these is arguably the single most important thing to understand because, well, it dictates management, doesn't it? It doesn't just appear and stay put.
That's the absolute defining feature, and it's crucial for revision. You see, they often aren't present right at birth,
Oh, okay.
though about a third can be. More commonly, they appear within the first few weeks, maybe starting as just a faint mark or a flat spot.
A subtle start then.
Yeah, and then they enter a phase of rapid growth.
How rapid are we talking?
Typically, this proliferative phase, the growth phase, is most active until the infant is around, say, 9 months old.
Right, up to 9.
This is when the lesion gets bigger and becomes much more prominent. But here's the critical part, the key takeaway. After that, it spontaneously starts to regress.
It shrinks away on its own. Seriously.
Yes, it involutes, that's the term. This regression phase is much slower than the growth phase, though. It takes years.
Years, okay.
Most of these lesions will have resolved completely by the time a child is 10, maybe 12 years old.
So the key thing here is grow fast early on, but then the vast majority just disappear by themselves over time.
Precisely. Understanding that natural history is fundamental.
That natural regression is definitely a game changer for management, which we'll get to. But first, why do these happen? What's the etiology?
Well, the exact cause isn't fully pinned down, unfortunately, but the underlying mechanism involves abnormal proliferation of blood vessels during fetal development.
So something goes a bit wrong while the baby's developing.
Essentially, yes. Think of it as a localized area where the instructions for building tiny blood vessels went a bit haywire, causing them to sort of multiply excessively in one spot.
It's like an over-enthusiastic construction crew building too many pipes in one corner of the building. Is that a fair analogy?
That's a great analogy, actually, a burst of building activity for blood vessels. While the precise trigger is unknown, genetic factors and hormones are thought to play some role.
Now, you mentioned something important earlier, listed within etiology in the sources, the potential for complications. This feels like linking the what and how to the potential impact.
That's exactly the connection we need to make for clinical practice and exams. While most hemangiomas are uncomplicated, maybe around 10% can cause issues.
Okay.
And these often stem directly from where they are located.
Location, location, location.
And the speed of that initial proliferation we just talked about.
So location is a major red flag then?
Absolutely. Lesions in critical areas need immediate attention. Think about the airway, the oral cavity, or critically, the eye.
The eye, why specifically?
Well, a hemangioma growing on an upper eyelid, for instance, can actually obstruct vision during that critical period of visual development.
So it could cause lasting sight problems.
Potentially, yes. It could lead to amblyopia or lazy eye if it's not managed early. Also, rapidly growing lesions on the head or neck can, although rarely, even interfere with breathing.
Okay, that's serious. Are there any other specific locations that should trigger further investigation, like clues on the surface?
Yes, definitely. And this is a high-yield point for exams. If you see a hemangioma located over the midline of the back,
Midline back. Got it.
that should raise your suspicion for an underlying spinal dysraphism.
Okay, hold on. Spinal dysraphism. Can you just clarify what that is simply?
Sure. Spinal dysraphism refers to a group of birth defects where the spine or the spinal cord doesn't close properly during fetal development. Think spina bifida spectrum, essentially.
Right.
So a hemangioma in that specific midline back location can be a surface marker, a kind of clue that something might not be fully formed underneath. It warrants investigation, maybe an ultrasound, or even an MRI of the spine.
Wow, okay. That's a really important connection. A visible sign potentially pointing to a hidden internal issue. Are there any other, perhaps rarer, conditions associated with hemangiomas that are worth knowing for revision?
Yes, though they are rare, two important associations come up. First is Kasabach-Merritt syndrome.
Tessa.
It's a very serious, potentially life-threatening condition. It's linked to large, often complicated hemangiomas or other specific vascular tumors like caposiform hemangioendothelioma. It involves platelet trapping within the lesion.
Platelet trapping.
Yeah, the lesion basically consumes platelets, leading to very low platelet counts, thrombocytopenia, and consequently serious bleeding problems.
Okay, very serious. And the other one?
The other is PHACE syndrome, PHACE.
And what is PACE syndrome? Is that an acronym?
It is, yes. It's a neurocutaneous syndrome. PACE stands for posterior fossa brain malformations, large hemangiomas, typically facial ones, arterial anomalies, cardiac defects, and eye abnormalities.
Whoa, that's a lot.
It is. So a large facial hemangioma might be the first clue that alerts you to this complex multisystem disorder. While rare, recognizing these associations is vital.
It's fascinating here how a seemingly straightforward skin lesion can sometimes be the tip of the iceberg, really highlighting the importance of a thorough assessment. Okay, moving on. Are some babies more likely to get these than others? What are the associated risk factors?
Well, the sources state there are no specific known risk factors that absolutely guarantee development, but there are several factors that are associated with a higher incidence.
Okay, so associations rather than direct causes.
Exactly. These are factors we just see more often in babies who develop hemangiomas.
And what are those associations? Who is more likely to get these?
Female gender is a notable one. They are significantly more common in girls.
How much more common?
About a 3-to-1 female preponderance, so 3 girls for every boy, roughly.
Right. What else?
Prematurity and low birth weight are also strongly associated.
So small babies, early babies.
Yes. Other factors that pop up include a positive family history.
Runs in families sometimes.
It seems so. Also, multiple gestation, like twins or triplets, and even a history of chorionic villus sampling, or CVS, during pregnancy.
Interesting.
Think of these as elements that might just flag a baby as potentially being at a slightly higher statistical risk.
Interesting how those epidemiological factors overlap quite a bit with what we consider risk factors. Let's quickly revisit the pathophysiology. How does that rapid proliferation actually happen at the cellular level? You mentioned endothelial cells.
That's right. It's down to the endothelial cells, the cells that line the inside of blood vessels. In these lesions, there's an abnormal and excessive multiplication proliferation of these cells.
But this multiply too fast.
Exactly. They form a densely packed area of vascular tissue. It's this rapid cell division and growth that creates the bulk of the hemangioma in those initial months, the proliferative phase.
Okay.
After that phase, the cells stop multiplying quite so rapidly, and the process reverses in the involution phase, leading to the shrinkage we talked about.
Okay, understanding that proliferation helps explain the growth phase. Now, shifting gears significantly, what else could a red raised lesion on a baby be? What are the crucial differential diagnoses we need to consider? What else is on the list?
This is critical, absolutely critical, for distinguishing the common benign infantile hemangioma from other things that might look similar but behave very, very differently.
Right. Top of the list.
At the top of the list, though, extremely rare in infants is angiosarcoma.
Which is malignant, cancerous.
Precisely. That's the one you absolutely don't want to miss. Other differentials include things like arteriovenous malformations or AV malformations, venous malformations, and importantly, congenital hemangiomas.
Congenital hemangiomas, you mentioned those.
Yeah.
What's the key difference again?
Right. The key difference is the timing and behavior. Infantile hemangiomas typically appear after birth, proliferate, and then involute over years. Congenital hemangiomas, on the other hand, are fully formed at birth. They don't grow after birth. And they typically either do not involute at all, that's a NICH, non-involuting congenital hemangioma, or they might involute very rapidly. Within the first year or so, that's a RIF-RIC, rapidly involuting congenital hemangioma.
Or on the H and NICH.
Got it. That difference in natural history present at birth, no post-birth growth, is vital for distinguishing them.
Right. So if it's there fully formed at birth and doesn't change or shrink slowly over years, it's probably not the strawberry you're focusing on today. What else might be on the differential list?
You might also consider a teratoma, particularly if it's in a location where teratomas commonly occur, like the sacrococcygeal area.
Yeah?
And then there's diffuse neonatal hemangiomatosis.
That sounds more widespread.
It is. It's characterized by having many hemangiomas, often small ones, scattered over the skin, and sometimes involving internal organs like the liver. This is a more serious presentation that needs careful evaluation.
So the takeaway here for revision is, while the classic strawberry is common and usually benign, always pause. Think about these other possibilities, especially the malignant one, angiosarcoma, and the congenital ones that behave differently.
Exactly. Understanding the differential helps guide your next steps, whether it's watchful waiting, investigation, or management.
Okay. Now let's zoom out a bit. How common are these generally? What's the epidemiology look like?
Globally, infantile hemangiomas are estimated to occur in about 4 to 5% of newborns, so pretty common.
4 to 5%. That's quite a few babies.
It is. The sources actually note that the prevalence specifically in the UK is unknown, which is an interesting detail.
Really? Okay.
But that global figure gives you a good sense of how frequently you might encounter them in pediatric practice.
And are there demographic differences in prevalence? You mentioned girls.
Yes, there are clear differences. As we touched on with risk factors, they are notably more common in Caucasian babies.
More in Caucasian babies.
Yeah, seen in about 5 to 10% in that group compared to Afro-Caribbean and Asian children where they are less common.
Interesting.
And again, just to reinforce, the female preponderance is strong, about 3 to 1.
3 girls to 1 boy.
And a higher incidence in premature infants and those with low birth weight. These epidemiological points really echo the risk factors we discussed.
Okay, so more common in Caucasian babies, especially little girls who are born early or small. Got it. Let's bring it back now to what you actually see. What are the key clinical features? Again, maybe building on our initial description. How does it present?
Okay, let's visualize it again. It's typically raised, bright red, sometimes a deeper red, soft, compressible to touch.
Like a strawberry.
Exactly. But the key clinical feature beyond the look is its evolution. Remember, appears in the first few weeks, usually, though sometimes right at birth. Then that period of rapid growth until around 9 months.
The proliferative phase.
And then the slow, gradual regression over years, the involution phase. That whole timeline is the clinical picture.
Where do we typically find them on the body?
The most common locations, by far, are the head and neck. That accounts for about 60% of cases.
60% head and neck.
But honestly, they can appear anywhere on the body. Trunk, limbs, anywhere. It's also fairly common for infants to have more than one lesion.
Oh, multiple.
Yeah, about 20% of infants with one will actually have multiple lesions.
And you mentioned a key number earlier regarding multiplicity. A threshold.
Yes, this is a detail worth remembering, clinically relevant. If you find more than 5 cutaneous strawberry naevi, so 5 on the skin.
More than 5.
That increases the suspicion for associated internal hemangiomas, particularly in the liver.
Okay, so the number of lesions is another potential red flag, a bit like location being important, and symptoms. Do they hurt or itch?
Generally, no. Most simple cutaneous hemangiomas are asymptomatic. They don't usually cause pain or itching unless they say ulcerate. The issues really arise, as we've discussed, when they are very large, located in those critical areas causing functional problems, or if they are internal.
All right, we know what it is, how it develops, what it looks like. How do we confirm the diagnosis? Do we need fancy tests for every single one?
This is where that natural history pays off again. Diagnosis is often primarily clinical.
Just by looking at it and hearing the story?
Pretty much, yes. Based on the characteristic appearance, the strawberry look, and the history of how it's developed, appeared after birth, grew rapidly, an experienced clinician can usually make the diagnosis confidently without needing further tests.
So when do we need investigations then? When do we need imaging?
Imaging, like Doppler ultrasound or perhaps an MRI, is typically reserved for specific situations. Firstly, if there's diagnostic uncertainty, maybe it doesn't look quite classic or you're considering one of those differentials.
Okay.
Or secondly, for complicated cases. If the lesion is very large, if it's in a critical area like the airway or around the eye, or if you suspect internal involvement based on location or number, then imaging is recommended.
To see how deep it goes or what it's affecting.
Exactly. To assess its extent and its impact on underlying structures.
What about biopsy? You mentioned bleeding risk earlier.
Yeah, biopsy can be done, but it should definitely be approached with caution. Remember, these lesions are highly vascular, lots of blood vessels.
Right.
So there's a significant risk of bleeding. It's usually not necessary for diagnosing a classic, uncomplicated infantile hemangioma, reserved for really uncertain cases, usually after imaging.
Okay. And the rule about multiplicity investigation, you mentioned the liver.
That comes back to that point about finding more than 5 cutaneous lesions. In that scenario, guidelines often recommend considering an ultrasound of the liver
Why the liver specifically?
because the liver is the most common site for internal or visceral hemangiomas when they do occur alongside multiple skin lesions, so it's a screening check.
Okay, so clinical diagnosis is the norm. Imaging for complexity, uncertainty, or suspected internal involvement. Cautious with biopsy. And screen the liver if there are lots of them, more than 5. That makes sense.
That sums it up well.
Now, the big question, management. If most disappear on their own, do we just watch and wait?
In the vast majority of cases, yes, absolutely. The primary management strategy for uncomplicated infantile hemangiomas is active observation or watchful waiting. Let that spontaneous regression do its work.
So no active treatment needed for most.
For most lesions, especially small ones or those in non-critical locations, no treatment is needed.
But there are scenarios where you do intervene. You have to step in.
Absolutely. Intervention becomes necessary if the hemangioma is causing or threatening to cause functional impairment.
Functional impairment meaning what
I
exactly?
mean, it's interfering with a vital function, like obstructing vision, compromising the airway, breathing, interfering with hearing, or making feeding difficult if it's around the mouth.
Okay.
Also, intervention is considered if it's causing significant disfigurement, especially on the face, where it might lead to major scarring or psychological distress later on.
And timing matters here.
Yes, early intervention is key for those lesions affecting critical functions like vision or breathing to prevent permanent damage or complications.
So, function and potential long-term disfigurement are the main triggers for treatment. What's the go-to treatment when you do need to act, especially for those still in that rapid growth phase?
The preferred treatment now, based on current guidance like NICE CKS and general NHS practice, is propranolol.
Propranolol, that's a beta blocker, right?
Yeah.
Usually used for heart conditions.
It is, yes. Oral propranolol is the established first-line treatment for problematic, proliferating infantile hemangioma.
How does a beta blocker work for a hemangioma? That seems counterintuitive.
It's actually fascinating. The exact mechanism isn't fully understood, but it's thought to work in a few ways. It seems to cause vasoconstriction, meaning it narrows the blood vessels within the hemangioma.
It reduces blood flow.
Reduces blood flow, yes. It might also decrease the production of growth factors that stimulate vessel growth and potentially even induce apoptosis or programmed cell death in those proliferating endothelial cells.
Wow. Okay. So it tackles it from multiple angles, potentially.
Yeah.
And how is it used? Is it a long course?
Typically, oral propranolol is started during the proliferative phase, usually in infancy, and continued for several months, often until around 1 year of age or until growth has clearly stopped and regression is underway.
And are there other options besides oral?
Yes, for smaller, thinner, or more superficial lesions, topical timolol is often used. Timolol is also a beta blocker, applied directly to the skin as drops or gel. It can be quite effective for the right type of lesion.
So propranolol, oral, or timolol, topical, are the main players when intervention is needed. What kind of specific situations really warrant this beta blocker treatment?
Think back to the complications we discussed. Propranolol would be indicated for lesions causing or threatening vision loss, like large eyelid hemangiomas, airway obstruction, feeding difficulties, large facial lesions causing disfigurement, or ulcerated hemangiomas which can be painful and bleed or get infected. Also, rarely for very large lesions causing heart strain.
Okay, let's run a quick scenario then, like an MSRA question might pose. Imagine you have a 3-month-old infant presenting with a rapidly enlarging bright red lesion right on the tip of their nose. It's growing quickly. Based on what we've just discussed, what's the most likely next step in management?
Okay, so 3-month-old, rapid growth, tip of the nose. That's a cosmetically sensitive area prone to disfigurement, and it's clearly in the proliferative phase. Functional impairment isn't immediate, but the risk of significant long-term cosmetic issues is high.
Right.
Therefore, the most likely next step, according to guidelines, would be to initiate treatment to halt proliferation and induce regression. The preferred first-line treatment would be oral propranolol.
Perfect example of linking the features, location, age, growth phase to the likely management strategy. Are there any other treatment options, maybe less common these days?
Yes, although they are used much less frequently now that beta blockers are established as first line. Intralesional corticosteroids injecting steroids directly into the lesion can sometimes be used to slow proliferation, particularly maybe for smaller localized lesions or if beta blockers aren't suitable.
Okay.
Interferon alpha has been used historically in very specific, often severe or life-threatening cases, but it has significant side effects. And surgical excision is an option too.
They're cutting it out.
Yes, but it requires careful consideration due to the vascularity and bleeding risk. It's usually reserved for smaller lesions that are easily removable, or sometimes for addressing residual tissue or scarring after involution has occurred naturally or with treatment. For very large or life-threatening lesions, a multidisciplinary approach involving pediatricians, dermatologists, surgeons, and maybe interventional radiologists for procedures like embolization might be needed.
So propranolol is really the headline treatment for problematic cases, but other tools exist in the toolbox for specific situations. Now, looking long-term, what's the prognosis like for these babies generally?
Generally speaking, the prognosis is excellent. Really very good.
It's good to hear.
As we've emphasized, the vast majority regress spontaneously without causing any long-term problems or complications. That natural history is key.
And by what age are they typically gone by? You mentioned 10, 12 earlier.
Yeah, complete resolution usually occurs by age 5 to 10 years, sometimes stretching to 12. The bulk of the regression often happens by school age.
Does the skin always look completely normal afterwards? Or can you sometimes tell something was there?
Not always absolutely perfectly normal, no. While often the cosmetic result is very good, especially for smaller ones, some cases might be left with minor lingering effects.
Like what?
You might see some residual telangiectasias. Those are tiny widened blood vessels on the surface. Or there might be slight textural changes in the skin, maybe a bit of wrinkling, atrophy, or slight discoloration where the haemangioma used to be. But overall, the functional outcome is usually excellent, and the cosmetic outcome is typically very favorable, especially compared to how it looked during the growth phase.
That's definitely reassuring news for parents. Finally, let's just quickly recap the potential complications, reinforcing why we monitor them closely and sometimes intervene.
Right. So important to remember, most lesions do not cause complications. But the potential ones we've touched on include ulceration.
Where the skin breaks down.
Exactly. That can be quite painful, prone to bleeding, and can get infected. Bleeding itself can happen, though often it's minor, maybe just oozing, unless the lesion is traumatized or it's part of a syndrome like Kasabach-Merritt. And infection of the lesion itself is possible, especially if it ulcerates.
Okay. And linking back to management triggers.
Exactly. The most significant complications, the ones that usually drive treatment decisions, arise from that functional impairment caused by the lesion's location and size obstructing vision, blocking the airway, interfering with feeding, etc. That's why regular monitoring by a healthcare professional is crucial, especially during infancy, to catch these issues early and intervene appropriately with treatments like propranolol if needed.
Okay, brilliant. We've just done a really high-yield deep dive into infantile haemangioma, also known as strawberry Naevus. We've covered its definition, that fascinating natural history of growth and shrinkage, potential causes, and those important associations like PACE and Kasabach-Merritt, the red flags like location and number.
The risk factors, what's happening at the cellular level, what else it could be, those differentials, how common it is, and who tends to get it, what it looks like clinically, and its growth pattern.
How we investigate it when needed, the crucial management approach focusing on watchful waiting but using propranolol for problematic cases, and finishing with the generally excellent prognosis alongside those potential complications to watch for.
It's a lot packed in, but hopefully focusing on these core concepts, especially the natural history and the indications for treatment, is really key for mastering this topic for revision.
Absolutely. For more free MSRA revision resources, remember to visit freemsra.com, and for the full premium revision toolkit, head over to pastthemsr.com.
Keep up the great work with your revision.
Keep reviewing, and best of luck with your studies.